subtypes of follicular lymphoma. So the indications for treatment for those subtypes would be the same as the standard indications, or would they be different?
I think if you're referring to the new entities of the WHO classification, which are particularly favorable, often those don't need any treatment and they tend to present as localized disease. But in general, for stage 3 or 4 follicular lymphoma, the common criteria which I use to make a judgment of whether a patient needs treatment or not is still the JELF criteria, which takes into account bulk. So stage 1, a disease, or 1-2, which is contiguous, if it is amenable to radiotherapy, our center still, we prefer to use radiotherapy because at least 50% of the patients don't recur with radiotherapy for stage 1 or 2 disease. So stage 1 or 2, radiotherapy. Stage 3 or 4, if they meet JELF criteria, we treat. And for those newer entities in the WHO, often they present as a single site of disease. The surgeon takes it out for the diagnosis and there's nothing else to be done.
So another question I have is MRD in lymphoma. So educate me about the value of MRD in low-grade lymphomas.
So in follicular lymphoma, looking for a 14-18 translocation at the molecular level is a powerful tool. However, this is not available, and we know from the data on studies that the deeper the minimal residual disease response, the longer the duration of response, and patients tend to do better. However, it's not something which is right now available on the day-to-day practice. It's still considered investigated, and it's not easily available, let's put it that way. But the deeper the MRD status, the deeper the response.
Sure. Any questions from audience?
The question. So for diseases like CLL or low-grade lymphomas, where we see there are many options in treatment, but the overall survival is similar, and patients are older to begin with. Is there any study looking at the quality of life of these patients? Because I think it's going to be a discriminant factor in picking and choosing the right regimen, not only the toxicity in terms of organ toxicity, also the overall quality of life. Is there any data on this?
So I think I showed you all in follicular lymphoma at least 2 studies. One is on the observation versus giving rituximab. There was no impact on the quality of life. It's either way, so people who observe, it's not that they did worsen quality of life. And there was another one on BR compared to R-CHOP, and the quality of life was in favor of the bendamustine-containing regimen compared to the R-CHOP. So certainly there are many more out there, and again, the data on that is a little bit all over the map. I showed you the 2 studies relevant to my talk, but there are studies out there which also favor that some people have less anxiety when they're on treatment than being observed. So I do think the toxicity part of it is important because these are chronic diseases. And I'll let you answer the CLL question.
Sure. I think similarly so, and I didn't present those, but for the 5-year follow-up of the ibrutinib data, there are patient-reported outcomes data that, again, seem to parallel the same, which is that I think that there are different issues for patients that are on continuous medications. So overall quality of life may be improved, but as you go on longer, and the rate of discontinuation of these drugs may increase with additional duration, and it can change over time. But these are important outcomes that are starting to be looked at in a number of CLL studies as well.
Now, another question I have is with ibrutinib, it causes bleeding complications in many patients. For example, somebody is on anticoagulant, you would not give ibrutinib, correct?
So I think about those patients very carefully. So there are certain patients who are on long-term anticoagulants where we might anticipate that they have a higher bleeding risk being on the ibrutinib, but I think with safe and close monitoring you can manage that. Where I tend to find in my own practice that it is much more challenging is on patients who are on an antiplatelet of some sort and an anticoagulant. So that tends to be the patients who have more cardiac disease, and they're much like you see in the antiplatelet and anticoagulant world. 3 is worse than 2, and so you have to be very cautious about that. But I think even patients who are on anticoagulants can receive BTK inhibitors. You just have to be very careful. The patient has to be very well educated about toxicity.
The question I have is, choice of anticoagulant. Like if you have somebody, at least in the ibrutinib, I find it very difficult to manage them when they're on Coumadin. So that, for me, is like sort of I use that as a
about somebody who is on NOAC, newer oral anticoagulants?
Much better than
Much better.
warfarin.
And
I think the Coumadin is the main problem.
Yeah, and those patients are excluded from almost all of the treatment studies.
I just want to emphasize that, yeah, I mean, anticoagulation is not a contraindication to ibrutinib therapy. In fact, in the FDA label also, it's not mentioned as a contraindication. Only thing is we have to be extra careful. And I have patients on anticoagulation whom I thought ibrutinib is still the best choice. That's why I'm keeping them on. They may need much more monitoring. And I agree with the mention that warfarin has been the main issue. You know why it is much easier.
so I have a patient who is on ibrutinib and for last several months came with dramatic subconjunctival hemorrhage, which was spontaneous. What would you do in that case? Has no other bleeding complications.
Subconjunctival hemorrhage is so common, and it's very difficult to say it is because of anticoagulation of the drug.
Right.
And many of them spontaneously resolve also. I certainly would get a good exam to make sure there is no bleeding inside. And if it is entirely subconjunctival, I'm not sure I will make any change, unless of course the patient is on warfarin. I have to make sure that the INR is therapeutic. Dr. Shah, if I can ask a question about the radiation question that was mentioned before. So localized stage 1 to low-grade lymphoma, Dr. Advani mentioned that radiation is what you would recommend because about 50% of the patients do have long-term. And that used to be my recommendation to patients based on the original Stanford and the St. Bart's data. But there has been studies indicating that even if you watch them, the long-term outcome is similar. So nowadays, I tend to give both options to the patient, especially if the location of the tumor is in such a place that radiation could add more side effects. I just want to get your comments on that.
Yeah, I mean, absolutely. When I said it has to be amenable to radiation. So, for example, if it's a mesenteric node or retroperitoneal node, we won't radiate. I'm talking like if you have like a groin node or an axillary node and it's an older patient and it's just stage 1 disease, those are the situations. The Lymphoid data show that observing these patients or radiating or actually even treating them with chemoimmunotherapy, the overall survival was identical with whatever modality which was used. And because at Stanford we have very good radiotherapy, and I trust my colleague a lot in radiotherapy that we actually make a joint decision. And you can think it's very easy to. The other thing to remember is you don't really need the higher doses. For frontline follicular lymphoma, there's a randomized study from Britain which showing that just 24 gray is enough and controls it very well. And in the palliative setting, a total of 4 gray is all we use with excellent local control. So I think this is something where if you team up with your radiation oncologist, you actually make a really good decision for the patient.
Although I know Dr. Advani is not a radiation oncologist, but everyone should know the indoor chair she has is from Saul Rosenberg, so I just don't want to be biased.
He's a medical oncologist also.
So, if you have any questions, please raise your hand.
Okay, so for Dr. Advani as well, you mentioned that early relapse is one of the most important findings, and that those may be the patients you want to take to transplant. Are there data that the transplant setting is beneficial for those patients?
So I think I showed you all 2 studies at least where, again, we don't have any prospective studies, but there are 2 retrospective studies, one from Lymphoid and one from the transplant registry, which looked at patients who had progressed. They looked at all their patients retrospectively and weeded out the ones who went to transplant because of relapse within 2 years. And the outcomes of those patients certainly seem to be better than historical controls. Now remember, follicular lymphoma, the median age is about 68. So you don't have, the patients have to be fit and be able to go to transplant too. So I don't think there's a whole lot of patients, but especially if you have a younger patient who has relapsed within 2 years, I think the threshold to refer to transplant should be lower than what we typically have.
I have 2 questions. First, about the monoclonal antibody against CD47. Since it's not activating the T cells, does this mean less autoimmune problems? And the second question is about the BR. We always say, BR. What is the dose you use? goes from 70 milligram up to 120 milligram. So what is the correct dose for both follicular and CLL?
So I'll answer the follicular question. So in follicular lymphoma, for a healthy younger patient, say up to age 70, we do 90 per meter squared day 1 and 2. And if it's somebody who has renal compromise or is older, I tend to start out at 70 per meter squared and see how they tolerate it. The 40, you want to take the 47 question? You want me to take it?
What you mentioned, the presentation is the responsibility.
Right. There is no, we don't, unlike the other checkpoint inhibitors or the other immune therapies, so-called like CAR-T or something, in the initial experience of 47, we have not seen any immune-related reactions. I mean, the worst side effect we saw was anemia, which is because of a class effect of the drug, because as our red cells age, we express CD47 to tell the body not to eat me so that the cells can live longer. And the minute you block that signal to an eat me signal, you can get transient anemia, and that's not seen in the reticulocytes of the baby red cells. So it's just a dose effect, which is mitigated by actually giving a priming dose. So you get rid of the older cells and then the newer cells don't have that. We haven't seen cytokine release. We haven't seen neurological symptoms. We haven't seen skin rash, arthralgias. Again, remember, this is a phase 1 study. It's quite an early experience, and time will tell.
Well, if we have no other questions, we have a break right now, so I'll see you at 10:20 in the morning. So